Right. Good morning, good afternoon, colleagues. Thank you for joining us today. My name is Bertha Snilstveit. I'm the Director of Synthesis and Reviews at 3IE, and I'll be chairing this session. A warm welcome to this launch event for the Sexual and Reproductive Health and Rights Evidence Gap Map. Universal access to SRHR is part of the UN Sustainable Development Goals for 2030. Yet there are huge challenges in achieving equitable SRHR services, particularly in low and middle income countries. This evidence gap map was commissioned and co-produced with colleagues at the German Institute for Development Evaluation, with support from the German Federal Ministry for Economic Cooperation and Development, BMZ, as well as Co-Impact. At 3IE, we're very grateful for both the support and the collaboration. The map explores the state of the evidence base on SRHR in low and middle income countries, and it will inform an upcoming evaluation of German development cooperation in the sector. We hope and think that this will also be a useful resource for practitioners and decision makers working to promote the use of evidence in the sector, as well as a tool for informing strategic research investments, whether that is in primary research or in evidence synthesis. And the team will share more details of that shortly. Just a few technical details before we get started. So first of all, to note that this event is recorded and it will be shared with all of you after the event. We welcome questions, and so I encourage you to use the Q&A function, so not the chat, use the Q&A function to raise your questions and indicate if the question is for a specific panelist. And also to say, it's always nice to know who we have with us. So if you want to use the chat function to introduce yourself and where you're based, that would be nice. We have to present the presenters and panelists that we have with us today. We have Thomas Kosakiewicz, Lina Khan, and Megha Bhattacharya from 3IE, who led and did a lot of the work on this piece. So they will present and discuss the findings. We'll then be joined by Martin Bruder, who's the head of the Department for Civil Society and Human Rights at DEVAL, as well as Mira Frey, who's an evaluator at DEVAL, and they will share their reflections on the evidence gap map. Then we have some distinguished panelists. So we have Sarah Gitome from the Sexual, Reproductive, Adolescent and Child Health Program at the Kenya Medical Research Institute. We have Shagun Sabawal, who's the Asia Regional Director at Co-Impact. And we have Siva Tanantiran, who's the Executive Director at the Asian Pacific Resource and Research Center for Women. And so we'll first have the 3IE team present the evidence gap map findings. Then we'll hear from Mira and Martin, and then we'll turn to an open discussion with the panelists. So with that, over to Lina and team.
Thank you, Birta. We're Pleased to welcome everyone as we present the findings from our evidence gap map about SRHR in low and middle income countries. For this presentation, I'll also be joined by my colleagues Megha Bhattacharya and Tomas Kozakevich. This map was a joint effort across multiple stakeholders, and we're grateful to the core team supporting this map, including Deval and Co-Impact. We'll first provide an overview of evidence gap maps before going into more detail and background about the SRHR EGM and our main results. EGMs visually show the presence or absence of evidence about the effectiveness of policies or programs within a specific thematic area. The maps are built on a framework for types of interventions. This is shown on the left-hand side, and outcomes, which are shown across the top. And those are measured for a particular program area. We call this the intervention outcome framework. We then run a systematic search for studies and map them onto the framework. The colors on the map show different types of studies. The gray circles show impact evaluations, or IEs. These studies set up a counterfactual comparison to the program being studied as a way to attribute change to the intervention. And we've included experimental study designs and quasi-experimental study designs. The circles that are showing different colors are for systematic reviews, or SRs. These types of studies look for multiple impact evaluations, and if they can, they pool results across studies to be able to say if multiple studies have found effects for a particular type of program. The size of the bubble in each of the cells shows the relative number of studies for the map. Finally, there are filters across the top of the screen, and for the SRHR map, we have quite a few filters that can allow you to search for studies by areas of interest. For example, you can search for studies by country, by population, implementing actor, among many others. The key thing is that EGMs are a way to visually highlight gaps. For example, it's a way to see absolute evidence gaps where few or no impact evaluations or systematic reviews exist. This is shown by the dark blue rectangle. And another type of gap are synthesis evidence gaps. And in those instances, you might have many impact evaluations, but no recent systematic reviews that meet a high standard. Gaps and clusters lead to further questions. They don't tell us why there is no evidence. And also the map does not tell you which interventions are effective at achieving different outcomes. The focus is on what is being studied. Where no evidence exists for an intervention or from a relevant geography, this is where it can be useful to consider commissioning an impact evaluation. And where a cluster of impact evaluations exists, but there are no recent systematic reviews that follow good practice, we would suggest considering commissioning a systematic review. We'll be sharing a link to the SRHR map online, and we hope that everyone has a chance to explore the studies further. I will now turn over to Megha to discuss in more detail the background for the SRHR EGM.
Thanks, Lena. So I'll just briefly go over what the background for our EGM was. Our SRHR EGM aimed to inform research agendas and investments to fill important gaps in the evidence base in this area. So we do this by facilitating access to relevant and timely studies and by highlighting where gaps exist and where more studies might be needed. We hope that this EGM will serve as a starting point for navigating the evidence base and will help inform program design and evaluation for similar types of programs or contexts. So how do we define SRHR? For our EGM, we adopted a broad definition of what consists of sexual and reproductive health and rights, which is that SRHR encompasses the right to bodily autonomy and choice, that is to make sexual and reproductive decisions, and to access services for the same. The definition of SRHR is reflected in the intermediate and longer term outcomes of the programs that were included in our map. These outcomes refer to both the quality of SRHR services as well as the extent to which interventions address long-standing challenges faced not just by individuals, but also communities and health systems. To that end, we have categorized these outcomes into 6 domains, which are knowledge, attitudes, and normative change, behaviors, service availability, acceptability, and quality, health outcomes, gender-based violence and harmful practices, and finally, enabling environments. So in order to identify important and relevant SRHR programs and interventions, we had an extensive consultation process with our advisory group, DEVAL, German development cooperation stakeholders, and our subject matter expert. We focused on 4 key intervention domains, which were prioritized for the EGM through this consultation process. These include SRHR policy advocacy and health systems, behavioral change interventions for the public, SRHR services, and finally, vouchers, cash, or in-kind transfers. Just to mention, within each of these domains, there are also multiple categories of interventions. Lastly, the interventions that we have included in our EGM also cut across various pertinent SRHR topics, which were adapted from the Guttmacher-Lancet Commission report on SRHR. In the interest of time, I won't go too much into detail about the same right now, but if you'd like to know more information about our inclusion criteria, it can be found in our full report. I will now hand it over to my colleague Tomasz, who will speak about our EGM's main results. Thank you.
Thank you so much, Megha. I hope you all can hear me. In terms of the main results for the evidence gap map, after screening almost 30,000 studies from dozens of academic databases and specialist organization websites, we included over 1,100 studies. And as you can see on the chart to the right, evidence continues to grow. And there are 999 impact evaluations in our map and 147 systematic reviews. For those systematic reviews, we rated them as either high confidence, medium, or low. We gave them ratings based on how they, based on their methods, how they run their research strategies, the way they screened the impact evaluations they included, and for each included study, whether they looked at how high the risk of bias was, as to be able to say whether a program was effective or not. And out of all those studies, we rated 24 as having high or medium confidence, which means that we have more confidence in those particular studies that their effectiveness findings are accurate and reliable. At the same time, we assessed 118 systematic reviews as low confidence. I think it's just important to mention that for those 118 systematic reviews rated as low confidence, it doesn't mean that they're low quality. It just means that we have less confidence in their conclusions about whether interventions are effective or not. Finally, for some intervention categories, we found not that many impact evaluations nor systematic reviews, so we included qualitative studies as well. And for those categories, we focused on qualitative methods that aim to make some sort of inference on whether an intervention caused or contributed to an outcome. And the studies we included used methods like realist evaluation, outcome harvesting, contribution analysis, and process tracing. Out of all the SRHR topics drawn from the Guttmacher-Lancet Commission report, as you can see here on this chart, maternal newborn care interventions are the most commonly included studies in our map. Almost half of the studies evaluate such interventions, and this was followed by studies of contraceptives and family planning interventions, and those related to SRHR education, most notably comprehensive sexuality education, and also sexual and gender-based violence programming. Studies focus on sexually transmitted infections were relatively fewer due to our inclusion criteria that only included them if they were combined with at least one other SRHR topic. Finally, there were fewer studies focused on safe abortion and post-abortion care, and also for relatively recent topics such as cervical cancer, sexual function and satisfaction, or infertility. For interventions, many studies evaluated counseling, which we defined as a discussion between health providers and service users to help people make informed choices. 10% of studies evaluated such interventions. This was followed by provider capacity building and service adjustments, such as recruiting and training community health workers in Nigeria to deliver antenatal counseling. Slightly less, 9% studies. But I think really interestingly, almost half of studies included multi-component interventions, which means that they combined intervention domains categories from our framework, at least two different ones. For example, one component of service provision, such as counseling, with a component of social behavior change, for example, community mobilization. And an example of such a study is an evaluation from India of a program that trained, mobilized, and monitored government frontline workers with the aim of better connecting people in marginalized situations to reproductive, maternal, and newborn and child health services. In terms of outcomes, the most commonly measured ones were those for service availability and use. 45% of studies examined such outcomes, and also slightly less than a third, respectively, for measures of knowledge and awareness around SRHR, associated rights, laws, commodities, services, including provider knowledge, and also measures of normative change and changes in gender norms, attitudes, beliefs, perceptions around SRHR, and related topics, including norms and attitudes of health providers. Now, in terms of, so now we discussed the concentrations of evidence. I'll finalize with some comments on the gaps. So for interventions categories, we identified gaps mostly in the service delivery and management domain. So for example, for policy advocacy, we found no studies, but we did find we find no impact evaluations nor systematic reviews, but we did find 3 qualitative evaluations seeking to answer a causal inference question, very valuable from our point of view, as it supplements the IE and SR evidence. For civil registration and vital statistics, we found no studies, though we did find one study where civil registration vital statistics were combined with a technology-based intervention. One study for supply chain and logistics, 6 for social accountability, 9 studies for safe abortion and post-abortion care, and finally 6 for in-kind transfers to influence SRHR-related behaviors. Just one final comment before I move on to the next slide. In some cases, for those interventions, rather than the lack of interest, some of those gaps could stem from there being fewer of such programs being implemented compared to other programs, or that they depend more heavily on national government processes, or even that they require other considerations to evaluate. There could be many reasons for that. Just wanted to make that clear. And finally, for outcome gaps, also, well, those are divided into 2 broad groups. The first one on policy and data tracking, starting from this kind of very high level, perhaps unsurprisingly, we found no evidence for high level international norms outcomes, such as the establishment of international agreements, guidelines, ratification of conventions. But if we go a step lower to the legislative environment category, which measures the extent to which rights are protected or discriminated against by adopting national laws, policies, and reforms of the delivery of care, we did find 6 impact evaluations and systematic reviews for those. At the same time, there were 5 qualitative evaluations that supplemented evidence on that rare outcome. For example, an evaluation that used contribution tracing to evaluate the program to protect gender diverse populations' rights and promote their access to justice and services in Bangladesh. So you'll find that study if you dig through our map. And also, the final policy data tracking gap relates to measures of registration for statistics such as birth, marriage, and vital registration. Only 8 studies examined such outcomes. So that's the first big group of gaps, policy and data tracking. The next one is harmful practices that disproportionately affect adolescent girls. We found no studies for trafficking, defined as any measure signaling the use of force, fraud, or coercion to exploit an individual for profit through forced labor or sexual exploitation. We found 4 studies for incidence prevalence or other measures of female genital removal or cutting, and a few more, 26, but still relatively low, given the importance of the subject for indicators such as the age at marriage and adolescents' marriage status. And also here again, I just wanted to caution that it's worth pointing out that for those gaps, there could be, rather than lack of interest, issues like measurement challenges that could contribute to the fact that we are seeing those gaps. So we know, for example, that there are challenges, longly recognized need for feasible and equity-sensitive ways of measuring trafficking and female genital cutting prevalence. Now, that's all from me, and I'll turn over to Lina, who will shed more light on the findings.
Thank you, Tomas. We also analyzed the data across geographies, and we found that impact evaluations were also scarce for some countries with high fragility or conflict. And these are also places where national indicators suggest that women may be more vulnerable to conflict-related sexual violence or reduce sexual and reproductive choices or health options. For example, no studies were found for each of the countries noted in red on this map across sub-Saharan Africa, the Middle East, and Southeast Asia. And we also found that studies focus on relatively few specific populations that experience vulnerability or marginalization. For example, we found only 2 studies that focus on people with disabilities, 3 studies that focus on people with diverse sexual orientations, gender identities, gender expressions, or sex characteristics. And other examples, only 5 studies that focus on people of minority religions or ethnicities, and about 7 studies that focus on indigenous peoples. We also looked at the level that SRHR programs were implemented. About half of the impact evaluations in our map studied interventions that were implemented at a local level. Expanding promising interventions could further SRHR aims and should be informed by the scale of the need, among others. Further evaluation could also build insight into achieving effective programs at scale. Also, less than 1/10 of the impact evaluations were pilot projects. We defined this as impact evaluations of interventions that were tested on a relatively small scale. And piloting new approaches at a smaller scale as part of a deliberative approach to program design and evaluation could also be of value. We would also like to share some highlights from included systematic reviews that we rated as high or medium confidence and that reported quantitative results. I would like to highlight a few caveats that results should be interpreted with caution due to, in some instances, the systematic reviews, including a small number of primary studies, some concerns about risk of bias for the primary studies that were included, variation in the way the intervention was implemented, or in some cases, a limited geographical coverage for those studies. That said, the systematic reviews covered quite a few topic areas within our map. For example, positive results were reported for mHealth and technology interventions on the use of antenatal care, as well as skilled providers during delivery. There were also positive effects found for task shifting across medical providers to administer long-acting contraception. This is task shifting from doctors to other medical staff, such as nurses or medical students, for example. In terms of other aspects of provision, there were positive effects reported for programs that supported self-managed medical abortion, as well as human papillomavirus, HPV, self-sampling as a screening method related to cervical cancer screening. There were also positive results reported for education and counseling interventions. This included maternal education for neonatal health outcomes and the use of antenatal care, counseling and education and related approaches to increase the use of contraceptives, and finally, counseling and related approaches to reduce intimate partner violence. All of these studies can be found in our map, and we definitely encourage users of the map to take a look at these studies in more detail. Some other takeaways for research and what we can do from here. There's a lot of information to work with. The fact that we were able to include over 1,100 studies shows that, but there's potential to make the most out of the evidence. The first is we suggest focusing primary research on the gaps noted by Tomas and myself. For example, key SRHR areas of health systems, safe abortion services, in-kind transfers. Another topic noted by a few systematic reviews were SRHR interventions in humanitarian context, as well as measuring harmful practices and changes in policy and data processes. I'd also like to note that areas with less serious gaps, for example, measuring service accessibility or affordability, could also benefit from further research so that we can improve the geographical or population coverage about that. We've also noted the value of having more study for countries with high SRHR vulnerabilities that are also generally facing conflict, and people in vulnerable or marginalized situations, including, among others, people with disabilities and people with diverse sexual orientations, gender identities, gender expressions, and sex characteristics. For study design, the growing SRHR evidence base has offered examples of ways to adapt evaluation approaches. For example, in conflict-affected settings, adding multiple intervention arms could be a way to help expand timely access to the intervention. And instead of a randomized controlled trial, other quasi-experimental approaches could be considered to help target interventions to specific groups of people whose needs existing services have met the least, or who face more barriers in using those services. And a last note on study design, we found relatively few impact evaluations used mixed methods, equity-sensitive research approaches, or reported cost information. Equity-sensitive approaches can help adapt research to the needs of or consider differences in effects for particular populations, which again, we feel is of value to better understand if services for SRHR are truly meeting the needs of everyone. Another area of gaps are synthesis gaps. We found clusters of impact evaluations that exist for various SRHR topics, but few or no recent systematic reviews that we rated as high or medium confidence. These were for topics such as SRHR policies and financing, family and community mobilization, health workers and the use of mHealth technology, provision of SRH products, and cash transfers, among other topics. The final point is about knowledge translation and evidence uptake. It can be useful to have a living EGM so that we're able to capture new evidence coming out and being published. It would also be good for us to learn from the participants on this webinar about how we can build on this tool to make sure that the evidence is used more extensively. Thank you. And with that, I'll turn it over to our DevOps colleagues.
Mira, I think you need to unmute.
Sorry about that. I tried to do that. Anyway, thanks so much. To start, we really want to extend our gratitude to our colleagues from 3IE and highlight that the collaboration and the process of co-creating the EGM has been really positive and fruitful from our side. We have really learned a lot through doing this together. And to start, I will present how we within the SRHR team use the EGM and also provide some thoughts on how to integrate EGMs into the process of strategic sectoral evaluations. Afterwards, Martin Bruder will provide some more general thoughts on what we at DEVA learned about the utility and use of EGMs in German development cooperation. So to start with, I want to share some of our needs and the rationale for commissioning this specific SRHR EGM. Given that our evaluation applies a human rights-based definition to sexual and reproductive health and rights, along the lines of the ones shared by 3IE, one key priority was that the EGM was using the same definition and approach when identifying evidence and related gaps to ensure its relevance and suitability for the evaluation. To align with our human rights lens, it was important to apply to the definitions used for the interventions and related outcomes. In the EGM development, we had weekly meetings with our partners from 3IE to discuss the findings used for these categories and adapt them if needed. Also, we had an advisory group consisting of key stakeholders that were consulted regularly to assure that their expertise was taken into consideration. Here, we also included German development cooperation actors. This was central to ensure that the categories align with the German development cooperation strategy we are evaluating. So interventions undertaken and outcomes desired by German development cooperation were prioritized, and the period from which studies were accepted started in 2014 after the launch of the Ministry's Initiative on Rights-Based Family Planning and Maternal Health. Ultimately, for us, this allowed for an EGM that is highly relevant to understand interventions and outcomes integral to German development cooperation and SRHR, but it goes so much beyond that. Additionally, to increase the relevant and meaningful contribution of the EGM, as mentioned before, we also included some selected qualitative studies. So that's based on that. And overall, as a co-producer and user, we want to highlight that EGMs can really be used throughout the entire cycle of evaluations. However, there are specific benefits to developing an EGM as early as possible to use it as effectively throughout the evaluation. Alternatively, instead of developing a new EGM, existing EGMs can also be used, which would be much less costly, but will also not guarantee the same degree of suitability and relevance. Our EGM was developed during the design phase. During the design phase, EGMs can be used to provide background information and to develop context factors affecting the interventions. When developing a theory of change, it can be used to validate through using scientific evidence whether intended interventions and outcomes actually follow the program logic. When designing an evaluation, the insights provided by EGMs can nourish the evaluation questions, especially if you are interested in contributing to filling existing gaps, or if you want to speak to a specific part of the existing evidence. Similarly, the evidence can also help determine which cases are of particular interest for the specific evaluation, be it regions or countries or populations. Because our EGM was not finalized during our design phase, we only partially used it for these specific aspects. In the inception phase of our evaluation, the EGM provided important information on the background and context factors. We used it extensively to describe the current situation regarding SRHR, as well as to cross-check potential influencing context factors, for instance, conflict. We also used the EGM to finalize our TOC, largely to validate the existing evidence on intended impacts of interventions. EGMs could also be used to investigate the detailed mechanisms connecting interventions and desired outcomes. Ideally, as it was the case for us, EGMs for evaluations are established in exchange with practitioners, which facilitates a matching of interventions and outcome categories used in EGMs and during projects. This can then also be used to design categories that match the EGM and the lived reality of development interventions. During data collection and the analysis phase, the current phase of our ongoing evaluation, the EGM provided useful context information to prepare case studies. The evidence gathered by EGMs can be used as a method in itself, through compiling it through an evidence synthesis, looking at a particular subset of the evidence presented in the EGM. We are currently doing this with regards to our evaluation criteria, efficiency and sustainability. So we are looking at only the subset of evidence provided that also includes these factors. When analyzing data collected as part of an evaluation, the insights from EGMs can also be very useful to cross-check and match existing scientific evidence and the information collected from practitioners. Overall, we use the EGM also to select researchers to consult for the foresight aspects of our evaluation. The variety of experts included in the EGM also allowed us to reach researchers from the Global South, which would otherwise be harder to find. Moreover, the different studies included in an EGM can also be an inspiration in terms of methods and provide good examples of practices and lessons learned. During the reporting phase, so in the next phase of our evaluation, we will use the EGM at different points. Again, as during the inception phase, it will serve as a base of sources to enhance the quality and validity of the report and our findings. Additionally, we will use the findings from the EGM that we use in our evidence synthesis to merge these findings with a portfolio of German Development Cooperation, as well as the analysis of evaluation reports. This allows us to match which interventions have been highlighted by the scientific evidence as particularly impactful, efficient, and/or sustainable with the interventions carried out by the German Development Cooperation. Finally, the gaps identified in the EGM can be used to formulate recommendations, for instance, by highlighting existing gaps and interventions, but also by pointing to new findings in case this was something that your evaluation was able to identify. Ideally, if an EGM was commissioned in an early stage of the evaluation questions were formulated to partially address gaps, leading to findings that might contribute knowledge and fill these gaps. Our EGM was commissioned at a later stage, but we will continue to use it as part of our dissemination strategy and link our results and recommendations to the EGM findings. As a key takeaway from our team, the SRHR EGM has been useful since it was developed and will continue to serve our evaluation all the way through to the dissemination of our results. Over to you, Martin.
Okay. I will take you on just a quick little journey even further away from the actual map on sexual and reproductive health and rights, and I hope you bear with me. We'll return to the content of the map very soon. So this is just to offer some more general reflections on the use of EGMs, because I can also see from the comments that at least for some of you, this may be a novel instrument, and I hope that what I have to say may help you to reflect on your use of EGMs more generally, but also, of course, on the specific SRHR map. What I will say is based on lessons learned from the use of this map and 5 other maps that have been commissioned by German development actors within the past years. These are on very diverse topics. One is on food systems and nutrition. One is on building peaceful societies. One on blended finance, climate change adaptation, and one final one on cash transfers and cash plus programs. So before getting into the lessons on these maps, just to say, if you're interested to learn more about German Development Cooperation and our use of evidence, we do have a website at DEWAL where you can find a current list of impact evaluations, evidence maps, and systematic reviews in German Development Cooperation, which is, you can see here, rie.deval.org. We also advertise registering completed evaluations that qualify for 3IE's development evidence portal, as we see that as the prime database for high quality impact evaluations and syntheses in international development. And if you would like to get an independent perspective on one of the donors who is not known for a very systematic, or hasn't been known at least for very systematic use of evidence in the past, that's also on that page. So what have we learned from using EGMs as a new tool? This is a complex discussion, and I'll just give you some headline impressions, which may be a little bit subjective. So what can they do? What can EGMs, which is evidence and gap maps or evidence maps, what's their advantages? They really can help structure, can facilitate structured thinking about the interventions and outcomes of a specific sector, and thereby create a common conceptual understanding of the topic area between all those involved in creating the map. And that can be quite a lot of people. And I think also in the case of SRHR, this has been a very inclusive process. They are also a great tool to collaborate with other development partners and also partner countries. In our case, that was the Green Climate Fund and the World Food Programme. In several cases, like in our climate change adaptation map and also the Peaceful Societies map, they successfully guided synthesis efforts. That's what 3IE said before. You identify areas where you have a lot of evidence, but maybe you don't have the syntheses yet, and then you can step in with systematic reviews. They can be a foundational part of a broader evidence agenda. For example, guiding funding for impact evaluations. That was the Building Peaceful Societies map could fulfill that purpose. And they can form the basis to efficiently create spin-off products like evidence briefs and rapid evidence assessments, which are, for example, created on the basis of the food systems and nutrition map. Very interestingly, I think they can be combined with portfolio data to create heat maps showing whether interventions and evidence are aligned. That's very important for evaluation, when you can tell your stakeholders whether they actually are working in areas where there is or there isn't a lot of evidence, and whether they should use that or whether they should start producing some. They can also help the relevant units and development organizations to contribute to and to some degree shape international sector dialogue. So however, there are also some challenges connected to evidence maps. First, they are costly and require constant updating. Some of our maps, which are only 3-4 years old, actually would already profit from an update, which we as an evaluation institute, which moves on to other topics, so we are not invested in one sector in the same way that many of you are, we are unable to fund that. So there's a funding issue in that respect as well. Many users are also concerned about the fact that usually only few qualitative studies are included. I think here also quite some of the questions that we can see at the back end of this are already about qualitative studies. So that's definitely a limitation. We've also found that the qualifications to both creating a sound map and to making it useful to stakeholders are not yet very widely available. So the great quality of 3IE and some other organizations notwithstanding, there's also, researchers are just also themselves starting to get familiar with that tool. One final challenge is that the tool itself is not self-explanatory and is not very useful when used in isolation without a broader evidence agenda. The main reason, and I think that you may have picked that up in the presentation also, is that it does not provide easy access to the content of the studies and reviews included in it, but really only maps those studies. So the extraction of content, so really knowing what do we learn from it content-wise, that's kind of a second step. And if you haven't planned for that, then you're missing a very important part of the benefit in the end of the map. So just a final short slide, where do we go from here? I think 3IE also already mentioned there's living evidence maps. In our case, the GIZ-funded map on food systems and nutrition is such a living map. It's updated every 4 months, and I think that's just really the way to go. So all maps should be living maps. Such long-term efforts really then require, but also allow for more coordination and cost sharing between different actors. So this is not just one entity commissioning a map, but really organizations sharing in the constant updating of such a map. Also, there is an issue of EGMs being too expensive, and they could maybe become less expensive. It seems that they are an area where AI could help in at least some of the steps required to create an EGM. As far as the qualitative studies are concerned, this is a very difficult discussion, I think. We are hesitant to broaden the methodological scope of EGMs. We think they should focus on impact evaluations and those qualitative studies with a very strong causal claim. Still, clever integration across other databases, such as, for example, databases with project evaluations or with portfolio data, can greatly enhance their utility. And I think we are only at the beginning of that journey, really. And finally, and to sum up many of the points made before, we should avoid advertising specific fancy tools like evidence maps, but really build a collaborative evidence agenda within key sectors, such as, for example, SRHR. So sorry for taking you on that journey. I hope it was helpful, at least for some of you. And now we'll get to the discussion on the map and its contents. And over to you, Birte.
Thank you so much, Martin and Mira, for your remarks and reflections. I think it's very nice to see that the mapped out across the stages of planning and implementing the evaluation, how you drew on the evidence gap map. And I think, Martin, a lot of your reflections really resonate, and you know, I think particularly the importance of collaboration and coordination. We are very grateful for Deval's support in this area, but really the importance of bringing in others as well. So with that, we'll turn to the panel and hear some of your reflections. So if I can ask you to reflect from your perspective how the findings of the map is relevant for you, and also comment on whether there are results or gaps that are unexpected. So perhaps we can go to Sarah first.
Thank you, Birte. Thank you so much to the presenters for the wonderful presentations. I think it's pretty clear the relevance of these evidence gap maps and how they start to play into the research that we're doing. So my reflections really focus on, first of all, just how this resonates with the WHO's, that's the World Health Organization's, framework on social determinants of health, because it's heavily focused on equity. So equity in terms of services, and it looks at how various conditions in which individuals are born, grow, or work affect a wide range of health risks and outcomes. So I was very excited to see the EGM's focus on where the gaps are and really bringing out that there's an uneven distribution of research that's being done in different aspects, and the need for these studies to be focused on vulnerable populations, which would then help countries or institutions be able to bring up the research equity and health equity in general. In relation to my country, which is Kenya, where I work, and where my institution, the Kenya Medical Research Institute, is mandated to carry out human health research, I would say that Kenya has been very active in integrating SRHR in its national health agenda, particularly focusing on reducing maternal mortality, improving adolescent sexual health, and increasing access to family planning services. So it was, I mean, expected, and I wasn't really surprised to see that a lot of the impact evaluations are focusing on maternal and newborn care, which also to some extent is driven by the research donor agenda, research funding donor agenda. And our health research prioritizes interventions that can address disparities in health access and outcomes, particularly among underserved and vulnerable populations. But the EGM also brings out certain gaps in areas which are critical to Kenya's priorities, where we're not matching the research to the priorities that we have. For instance, there's limited focus on displaced persons or persons who are facing different kinds of vulnerabilities related to conflict. For instance, people who are in refugee status or who are marginalized in one way or another. Also, there was less evidence on certain vulnerable groups, especially for me, what comes to mind is the sex workers, yet there's a lot of HIV-related work going on in the country that addresses commercial sex workers and also addresses needs of men who have sex with men. So it was a little surprising to see that we have limited evidence on that. And then some of the other things that, again, stood out to me is that we have a very strong focus on the community health strategy, and it's very similar to other low and middle income countries, especially in sub-Saharan Africa, where we rely on the community health strategy to sort of bridge that last mile in terms of getting the services to the people and also connecting the people in the community to the services that they need to access at health facilities. So it was a bit surprising that there wasn't a lot of evidence on work going on in relation to the community health. And I think that's an area that would benefit from perhaps looking more into to see whether is it an issue of there's not much that's being researched on that, or are people researching on that but not publishing, or is it an issue of publication bias? And then there's also, for me in general, paucity of evidence in terms of policy and data tracking was also surprising, especially in the area of HIV and FP, family planning programming, because there's been considerable investment in data tracking in this field, as well as enhancing data quality. And I would have expected, again, more evidence synthesis in those fields. And then lastly, just thinking about vulnerabilities and the nuances that are there, because again, we don't necessarily always have discrete categories of vulnerabilities. Sometimes some vulnerabilities are a bit more normalized and may be difficult to identify. So some research may involve that, for instance, intimate partner violence, gender-based violence. Some studies may perhaps include that, but because it's a more normalized kind of vulnerability, then it doesn't really rise to the top when it comes to the evidence synthesis. I'll stop there for now. Thank you.
Thank you, Sarah, for those comments. Very useful. Shagun, can I ask you to come in?
Yes, sure, Butter. So just again wanting to echo that this was a fantastic presentation, and thank you so much for organizing this event. I think it's very important that what 3i is trying to do is to really spotlight the importance of tools such as the evidence gap maps, but also taking the effort to really see how these can be used and the implications of having such tools exist in the as public goods, how that can really help us. So just starting to say, I'm Shagun from Co-Impact, and Co-Impact is a collaborative philanthropic organization. And for us, we are really working, we support organizations to really work with systems. And when we talk about systems, of course, there are the public systems, which, as you know, for things like health, majority of our population, especially in the low and middle income countries, they rely on access to services that are provided by the public system. But then you also have market systems, but majority of our work is really focusing on how organizations can work to make the systems better, to make the systems more inclusive, so that they really work for those who are marginalized, because if they work for them, then the system will work work for everyone. And from that perspective, I think I would like to say that when you're taking the systems lens, there are obviously many different levers, there are many different entry points that different organizations can pull, and evidence is actually one of the very important ones that often gets overlooked or doesn't get as much attention that it should. And when we talk about evidence, of course, there is the deep contextual evidence that we know, which is important, but also it's very important to have access to comparative evidence across the contexts. So because a lot of the themes that we are grappling with are sort of universal in nature, and there are, of course, contextual realities that may impact your evidence, but it's also very important for us to not forget that we should be learning from each other, we should be learning from other contexts, etc. So I think the evidence gap maps really help us to take a step back and just really look at the overarching picture, both in terms of where there are gaps to know more, what are some areas that haven't gotten the kind of attention that they deserve. And I think it's not just from the evidence purpose, but also maybe there's not enough programming that's happening in those areas, right? Like we know that there is, like, the gap map is telling us that yes, there's not enough impact evaluation evidence, there's not enough synthesis evidence, and maybe very little qualitative evidence, but that may also be associated with then there being a lack of programming in the first place in some of these areas, right? And then the second part is, of course, for us to think about, sorry, I've totally lost my train of thought, but basically what I was trying to say is that I think these gap maps are very, very important because, yeah, they also then tell us that when you look at in its entirety, where are we in terms of knowing and understanding about SRHR, for example. So from Co-Impact's perspective, we do think that tools like evidence gap maps are very important. We really encourage our own program partners or potential program partners to use this evidence to really inform, and just seeing this all in a way that's so easy to digest, that's so easy to understand, I think is a very good starting point. In terms of what emerged as surprising findings, I will say that overall, I think I was very surprised it's a positive news to also learn that interventions that are focusing on outcomes such as intimate partner violence are impacted through interventions like counseling. So I think that to me was really surprising because I would have thought that something like an intimate partner violence would require a lot of other types of interventions, but just hearing that something as simple as, it's not simple, but still counseling type of interventions are the necessary first step and that they can have the positive impact. So that really stood out for me. The second was the lack of evidence around access to safe abortion services. And I see that Shiva is here, and that also makes us happy that we are supporting the work of the Kaleidoscope initiative that she'll be talking more, because there is such an important need for us to really get this evidence together in terms of what's working. We are at the stage in the world where access to safe abortion should be really there. It should be, accessible. And yet, despite many countries having very open policies, it's still not trickling down. And the evidence gap is definitely something that stood out for me. The third thing I wanted to just highlight was that the positive impact of mHealth and technology, again, that was great to read and hear. I know that ever since tech has come in, it's become like the panacea and everything is around technology, but also knowing that, yes, evidence is supporting that in health, it can really support that. So those were some of the, some specific findings that I just wanted to share. In addition, I also want to just comment that the 3i team has just done such a fantastic job in categorization, because when we see this all together, it seems like this is how it always was. But there are a lot of decisions that you have to take. There are a lot of categorization that you have to do, both at the outcome level, but also in the intervention level. And that's not at all straightforward. So I really liked, it's very intuitive, and it kind of makes a lot of sense the way you have categorized these different, on both sides. So yeah, I think those were my main points. I would like to hand it back to Berta.
Thank you so much, Shagun, and I'm sure that the team will appreciate all of those comments, in particular the last one, because the framework can often be, it's a long journey to get there and sometimes painful. Siva, over to you.
Thank you, Berta. And I think that Shagun has already kind of, honed in on what my pet topic is. But I think that, it was really great to look at the evidence gap report, on the overall and in the big picture, right? Because it's such an important initiative, especially in the SRHR landscape, and of course, Arrow's particular interest is the Asia Pacific region. And because traditionally and unfortunately, I mean, while we talk about sexual and reproductive health and rights, so much of the work on SRHR has only been focused on, fertility reduction via contraception and family planning access, right? Instead of, the more comprehensive view of sexual and reproductive health and rights, as has been defined both, in the International Conference on Population and Development, Cairo, and later by the Guttmacher-Lancet Commission, which is the definition that is being used in this evidence gap report, right? And, because for the longest time, Asia has been seen, as a region which has averted the population crisis, on the overall, but, of course, with some significant countries having these access to contraceptive challenges, it is as an overall, as a region, largely overlooked, right? And within Asia, South Asia gets, more attention, and especially India, both by, both organizations as well as, donors and funders who commission research, right? But I have to remind that we are a very large and diverse region, which include, L&MICs such as, Laos and Cambodia, East Timor, and also the whole gamut of, the Pacific Islands, and we also have conflict countries such as Myanmar or Burma, and Afghanistan, and of course the spillover effects, of refugees across the borders, right, which we are also experiencing. So hopefully this will be a way in which we can actually start advocating, for more nuanced intersectional commissioning of research in the Asia Pacific region, because there are considerable gaps, in the realization of this universal access to sexual and reproductive health and rights, in the region. So then, of course, we come to the topic that, I really like, is and I'm passionate about, which is, the evidence report notes. And, it comes as no surprise that access to safe abortion is one of the issues where there is a significant evidence gap, both as within the interventions and the outcomes, right? And most probably this is due in the way that, the perception of how abortion as an SRH service, unfortunately, and historically has almost always been caveated, right, as an essential service. This is even in the international documents, right? Because even when they talk about family planning, and they have to define that contraceptive services do not include, abortion services, However, people who are in the field and who are working inside, we do know that abortion is an essential service to reduce maternal mortality, right? And so the report, and I think that this is really important because we know for sure, what gets measured is what gets funded, and what gets funded is where we are able to push the boundaries, right? Like allies such as ourselves, who are largely, regional organizations working with national, women's rights and feminist organizations on SRHR issues, but also, service providers. How can they actually say, look, we need to provide this service? And I think that, in the evidence gap report, it also comes out that one of the groups that is most severely left out, right, of SRH services are young women and adolescent girls, right? And this is the group, and the outcome that we can see is the rising proportion of, unintended pregnancies in this group, right? Because young women and adolescent girls suffer the double marginalization, right? Because they have both gender and age power hierarchies that marginalize them. They are the ones who would benefit most, as the report points, to interventions that have multiple services and health systems interventions, such as counseling, SRHR education, counseling for violence, as well as capacity strengthening of service providers, right? Which then can be connected to access to both contraceptive and safe abortion services. And I think that another one of the gaps that the report points to is that, the need for us to also look at, even within the work that we are doing, how can we actually, utilization of health service providers who are closest to the community, right? Such as, this informal service providers that exist in our part of the world, like lady health workers or ASHAs, right? To widen the ambit and reach of safe abortion services through the provision of self-managed abortion, which will really enable access for younger women who are already, suffering from this, double marginalization of both gender and age. So I think that, so it's a really great, report to come, because I think that it points to all of us to say, like, if we're really going to like kind of move to the next level, right? What are the necessary interventions? What are the areas that we need to look at? And within the evidence gap report, we can already actually look at what are some of these, these kind of essential programs that can have multiplier effects, across different SRHR services and throughout the entire life cycle, of women and girls.
Thank you so much for those comments. I'll turn back to Sarah to share your reflections on what you think is needed in the field of SRHR to better facilitate the use of evidence.
Thank you, Birte. So in terms of what is needed, I think one could look at it from the point of view of are we aware of these evidence gap maps? Are we aware of the utility of these evidence gap maps? As we are, for instance, setting our research agenda as countries or as institutions of research, do we refer to these evidence gap maps and to sort of inform what we are coming up with as areas of focus for foundational research? Because you'll find that there's a lot of perhaps redundancy in some of the areas. Like you may find that there's a lot of studies which are small studies which are looking at perhaps maternal and child health services provision, and they're just looking at different little components of these. Women's awareness, male partner engagement, child immunization, but they're just little sort of little pockets of research that is going on, but it's not really having the bigger picture of what is the evidence gap. So we've researched a lot on this, but we still don't know much about this other field. And bringing that together to be able to say, now we need to seek funding to really look at these priorities, which are aligned with our national research agendas or even the global research agendas. So that's one way at an institutional level that we can make use of these evidence gap maps. And then sort of informing how the institute or the groups that are carrying out this research can plug in to address these gaps. And then the other part is looking at, for instance, there's a lot of qualitative research that is done in most of the SRH programming. So we have a lot of qualitative research in, for instance, family planning, STI and HIV, maternal health services. And a lot of that somehow gets filed away. Some of it is published as single studies. Some of it just gets filed away, never sees the light of day in terms of publication. How can we bring that in our evidence synthesis so that we're looking at the whole picture rather than just saying quantitatively this number of women accessed family planning services, but why did this woman, this type of woman access services and this one did not? Why is this one facing particular vulnerabilities? Why is the adolescent and young girls, why are they being marginalized from services? What is their experience with these services that are being offered? We can also see a way of bringing that into the evidence synthesis. I think it can give a more holistic picture and further inform the kind of research that needs to be done in these areas. And then from a national level, I feel that there's a lot of, there's a wide array of sectors that can be impacted by evidence gap maps. So for instance, you've done this EGM in SRHR, which most of the countries, it will fall under the Ministry of Health. But there's a lot more that can be done when we bring in other sectors. So for instance, education sector, we're thinking about, like, one of the things that was highlighted is an evidence gap in terms of supplies. I think it was something to do with supplies. And that is not traditionally falling under the Ministry of Health, yet it impacts services and products reaching people, and especially those who are really marginalized from these services. So how can we start to train people to be able to plug in and contribute to this evidence, carry out research in these areas, because there's a limited research that's going on in those areas. And then we bring that in to inform how we can better the services that are being provided, ensure that these services are reaching the people who really need them the most. And then lastly, I think that these evidence gap maps can really be used to create or generate appetite for more evidence synthesis, where clinical trials, for instance, exist. How can we look at synthesizing the data or the findings from these clinical trials, either as systematic reviews, meta-analysis, or impact evaluations, informing impact evaluations? Creating that appetite also fosters collaboration across sectors, and also fosters collaboration across countries, so that we're looking at regional issues and not just the national issues, for instance. Thank you.
Great, thank you, Sarah. Shagun.
Yeah, sure. Thanks, Bertie. So I think what I would add to some of the points that Sarah has already made is to say that, one, I do feel that even at the level of interventions and programming and investments in improving the overall SRHR landscape, like with many other things, I think there is a lot of siloing that ends up happening, right? Like everyone, there are like specific issues and topics, and it's even, I mean, even from the funder community, right, where they feel like this is the only thing that we must invest in, and this is what we must do. I feel that evidence overall, and evidence gap map that's really trying to put the full picture together, can be a very powerful tool in trying to just get everyone together on the same page. I think that, like, because I feel like evidence is something that everyone cares about or should care about. And then when you see it in this form of a EGM, then you realize that just over-indexing on one aspect or one lever is not going to be enough. What is the big picture telling us, right? Like just Siva talked about how when we say so much about contraceptives, etc., we are in some ways pushing out the needs, etc., that are needed for things like, say, access to safe abortions, which are also equally important. So in some sense, it's almost like this neutral tool, but that can have a powerful effect of like really bringing the different actors and players in this field together. So that I definitely think is something, and I don't know if we use it so much. I think a classic problem with anything to do with research or evaluation or L&MI is that it has its own corner, and in some way it ends up alienating a lot of the people who should actually be using it, especially those who are in the implementing table or those who are in the decision-making table. So I also think that there is a lot we can do with this as a starting point. For example, the webinar you're now doing, because EGM has tried to make things quite simple. If you were to take a look at it, and it's very intuitive. There's a table that people should typically be able to understand, say, or as opposed to, say, a meta-analysis or a, it's much easier to digest, to understand, right? So I think that there is a lot that can be done to really improve the access and use by just disseminating and doing these kind of things and building bridges between the demand and the supply of evidence. So that was one thing I wanted to share. The second thing I wanted to say was that, again, I think it's very important that we also highlight the two like the twin goals of a gap map, right? Like it's not just about saying what are we inferring from what we are finding, which is again very important, but also to say that it's also telling us where the gaps are. So it's in the name that it's a gap map, but I think that the fact that you get two such good things in one go is very important, because if you look at a classic study or an impact evaluation, it can just say, these are the areas where we should do more work. Typically, most papers will end with that, but this really helps us see it, as in the sense of the entire context. I think the third point I'll say specific to SRHR is that there are a lot of different types of groups, including, I would allude to, like women's movements, the social movements that are much more grassroots, that really come from very like bottoms up kind of approaches. And there again, to go back to Sarah's point, they also help us see that who are the people who are being systematically left out in terms of their access. And especially when it comes to SRHR, we know with adolescent girls, etc., like how vulnerable they are and how there is such a little reach. So I think one thing is that while this is a very broad sort of, it helps us at a broader level, how can we then use these findings to say further from an inclusivity agenda? How can we use some of these findings to really push forward some of this? And it's not easy to marry both of these approaches, right? Like at Co-Impact, we talk about systems change. We also talk about having an intersectional and gender lens. And many times I feel that when you talk about intersectional and gender lens, it entails having very specific approaches, very bespoke ideas that work for that specific population, whereas systems change is a lot about scale and a lot about like having one size fits all type approaches. So how do you bring these two together? So I was thinking similarly, I think the gap maps can be a starting point, but then they can help us then zoom into some specific issues, some specific target populations that are not being addressed through the programming or through the evidence. I'll stop there.
Thanks, Shagun. So I'll hand over to Siva, and just to say that after that we'll take some of the questions that you will put in the Q&A. And so this is also a final chance for those of you that have questions to post those to the panel. So over to you, Siva.
Yeah, thank you so much, Bertie. And of course, again, thank you, Shagun, because you just made that kind of segue into like, how can we actually look at, when you put the whole evidence gap reports, right? And then we know exactly where to hone in and what are the types of, groups or marginalized groups that, we really want to address. And I think that, earlier on in the presentation, I mean, like, there were examples of complex settings, which were, humanitarian settings and conflict settings. But also I wanted to point out, that marginalized groups are located in complex situations, right? And I think in the earlier, in the first 2-3 decades, we were talking about, building certain types of systems, right? Where it casts as wide a net as possible to kind of look at, how can we bring more, either children or women or adolescents into our health system. But now I think, we're moving towards the era, and that's the demand that we can see and the gaps that we're seeing across communities, isn't it? It's like, how do we design health systems for inclusion, And, I was just trying to, think about like one of the groups that is most left out, and we did some, amazing work across a community of women and girls with disabilities in Bangladesh, right? And it was so, the situation, that let's say women and girls with disabilities are living with is like, complex, and because on the one hand, women and girls with disabilities are attacked for sexual and gender-based violence, due to their vulnerable situation. And SRHR of women and girls with disabilities at them as sexual or reproductive beings to start off with. Parents and caregivers very often deny the rights of persons with disabilities to be parents, or be in a sexual relationship. And practices such as forced permanent contraception, hysterectomy, and forced abortions are also practices that women and girls with disabilities experience, right? So we have a highly marginalized group, facing both great unmet and unaddressed needs of, but at the same time, they face SRHR violations. We design the SRHR services more intersectional, and beyond just service provision and ensure disabled access, right? Which is what many of our governments, have been carrying out, which is good, which is a good. But every context, the differences between the marginalized groups and mainstream groups are actually embedded even within, the legal systems and the institutional systems, right? Because in many countries, women and girls with disabilities, even when they have attained the age of majority, may never be able to give consent on their own, right? And then in the interventions that the report talks about, such as that SRHR education and counseling, which also includes, creating awareness and empowerment and capacity strengthening, of service providers in order to be able to serve marginalized group is also essential, before, a set of women and girls with disabilities, will be able to come, into a clinic, and avail of services, right? Even when they need them. So there's a great deal of kind of this intersectional work and interventions that need to be carried out if we are truly serious, in bringing marginalized groups into the system. Yeah.
Thank you, Siva. So there are a couple of questions for the EGM team around any plans to use AI for creating EGMs, and also around how newly generated information might be incorporated into EGMs. So I don't know if Lena or Tomasz, if you want to respond to that.
Yes, actually, excuse me. I'd like to loop in Tomasz, if you can speak a bit about the way we use AI for machine learning.
Sure. So, I mean, we use a different machine learning model to help us not have to screen through all the thousands of records that we identify using the search. So this is a really huge time saver, which has enabled us to do things quicker and cheaper. So basically reducing our screening effort by a lot. But we are definitely looking for other areas where AI could be used, possibly also in data extraction. We're kind of piloting different approaches of doing so, possibly summarizing studies as well to make sure that people are able to get what they need quicker. But this is still needs to be tested before we fully roll out.
Good. Lena, you're on mute.
Yes, thank you. Sorry about that. I'd also like to jump in. We had another question that I think was posed in our chat as opposed to the Q&A that was a useful one about, it was from Jennifer Musoke about how we can integrate EGMs in other sectors like gender, labor, social development, finance, and general health, and be able to disseminate it beyond researchers.
Perhaps that's a question that some of the panelists would like to address. I think several of you have mentioned the issue and importance of intersectoral working. So any thoughts on that?
Birta, if I could chime in, I think it starts with us and those of us who are here hearing about evidence gap maps and taking this information back to our places of work to start with. We have to be the ambassadors for this kind of information because many researchers may not be familiar, not even the decision makers or policy makers yet, but even researchers themselves may not be very familiar with evidence gap maps and how to use them to inform their research. So I think starting from there, creating awareness about this and then linking it to the work that's happening. It's always nice to use stories and to really connect the unknown to what people already know. So if you're talking, for instance, to finance decision makers, then perhaps you want to bring in the aspect of this is what we have been doing for the last, you can see from this evidence gap map that there's a lot of money and work that has gone into this particular area, but it's still not helping us to address this particular need. Perhaps we need to think about investing more in this other aspect. And the same case for these other sectors that Jennifer has mentioned, gender, labor, social development, cross-cutting sectors like law, and how do we bring this in? Because sometimes you have a legal or acts of law that are formulated that might be at loggerheads with how healthcare services are being provided. Both Siva and Shagun have talked a lot about adolescent girls and young women and how even when they attain the age of majority, may not be able to make certain decisions for themselves. So how can we use that, for instance, to change the way we think about law setting and law making to ensure that we don't make laws that continue to marginalize people that are already marginalized and marginalizing them further? Thank you.
Also, Birte, maybe I just wanted to also jump in here because, I think this intersections between like labor, gender, law, policy, and even the digital arena is, really huge, right? And if I can just like maybe, show two examples. I mean, as you know, these marches people have or these protests people have outside abortion clinics, right? I mean, like, what does that actually serve as a purpose, right? Other than to further drive stigma around abortion, right? And this is how, like, the frameworks are put in both in not only the woman who's seeking an abortion service that she doesn't have a right to do it, but also sending a message to all both the community as well as legal and policy makers, right? So for me, I feel like some of this, like protecting the democratic spaces, becomes so important. And so this is so necessary, especially with regard sexual and reproductive rights. And I think that one of the audience also had asked inside the questions about what do we do about, political conservatives, or fundamentalists, because we can see, these small vocal, groups emerging in almost every single one of our countries, right? So how do we actually frame our work also within the intersection of democratic rights and the right to health within, seeking access to services is, I think, one of those integral ways that we have to move forward in this how do I say, the era of which we all know is people are calling shrinking space, right? So yeah, so that's my 2 cents.
Shagun, do you want to have the final word, or?
No, I'm good. I think everyone's yeah.
Thank you to all of the panelists for a really rich and stimulating discussion. We're very grateful that you took time to join us today. I'm not going to try and sum it up, but I think that there are definitely important points made around vulnerable groups and sensitive interventions, and that's an important gap in the evidence base, as well as around the discussions around qualitative evidence, both how that's included in synthesis and what is a robust qualitative study. And then I think also, and for us, speaking for both for myself and I know for the team, reflections around evidence gap maps and I think essentially, highlighting that these are starting points. And I think Martin's term of a foundational tool for strategies for evidence-informed decision-making really resonated. I hope that you want to continue this discussion with us and engaging around how we can make sure that the EGM is as useful as possible. You'll see in the chat there is a link to a webinar that we are co-organizing with WHO EVIPNet. There will be an opportunity to dive into some more of the details, including discussions around kind of next steps when it comes to further research. So with that, thank you to our panelists and to our audience for joining us. Have a lovely rest of your days.
Thank you. Bye.
Bye-bye.
Thanks a lot.